reduction and pinning. I don't think there's any controversy at this point in time that if it's white and pulseless or pink and pulseless when it comes in, you need to go ahead and go emergently to the operating room for reduction and fixation. So what happens if after you reduce and fix it, it's white and pulseless? Well, I think that most of us would, agree immediate exploration is warranted. But what do you do when it's pink and pulseless? Do you just continue to watch it, or would you explore this? And this, I know, varies a lot from center to center. So in an attempt to try to clarify this, the Academy released their clinical practice guidelines a few years ago. And even though they could not actually find any really good evidence out there in the literature, the consensus of the panel was very, very strong that an emergent closed reduction of displaced pediatric suprachoroidal hemorrhage factors be performed if there's decreased perfusion. And again, they didn't really define what decreased perfusion means. And again, their second recommendation, which was a consensus statement but did not really have good evidence out there in the literature, is that if after you reduce and pin the elbow, the pulses are absent and the arm is underperfused, which again, not really quite defined what underperfused means, that you should have open exploration performed. But what happens when you have absent pulses and the hand is pink, warm, and well perfused? And again, they could not recommend for or against open exploration or to watch it. And if you look in the literature, the reason why you can't figure this out is because it's very confusing. It's kind of all over the place. Paul Choi, back when he was in CHLA, reported on a cohort of 33 children who were pulseless. The ones that were well perfused after surgery but still pulseless were observed and did fine. Again, not really defining what well perfused means. And then the ones that were poorly perfused, half of them did get vascular repair. So their conclusion was that if it was well perfused, it didn't matter whether it was a pulse or not, they did fine with fracture reduction alone. And there was a later study by Brian Scannell and the group out of Carolinas with long-term follow-up found that even with occluded brachial arteries, patients had very good collateral flow and good to excellent outcomes even with an occluded brachial artery, although one of these occluded patients did have the dreaded cold intolerance that we hear a lot about but don't really see a whole lot of. Then a meta-analysis out of Cincinnati looking at pulseless supracondylators in the literature found 98 of them, 70% of these had documented brachial artery injuries, and when they did further deep dig into the 54 revascularized patients, they found 91% of these were patent at one-year follow-up. So that old orthopedic dogma about don't explore the brachial artery, if they graft it or repair it, it's just going to clot off. Again, that's just orthopedic dogma, and that really wasn't borne out when you looked at the literature. So when we looked at our experience at Scottish Rite that we published, we reported on 54 pink pulseless elbows. We did find more nerve injuries were more common in the cohort that were pulseless than without. And 9% of our patients in this cohort did require vascular surgery after fixation. All 5 of these were pink and pulseless, but what they had in common is that they did not have a Dopplerable pulse after reduction and fixation. So this is how our cohort sussed out, is we had 54 that came in and were pulseless and got reduced in pin. About half of those restored their palpable pulse and did great. 20% had the Dopplerable pulse restored but did not have a palpable pulse, and those were all admitted to the hospital and observed after surgery. 4 of those patients had an immediate vascular procedure on the table. When you look at the 20 that had a restored Dopplerable pulse but not a restored palpable pulse, one of these patients actually deteriorated on the floor and ended up needing to go back to the operating room for a vascular exploration. And so when we look at the 5 patients who did get explored, what you can see they all had in common was that the pulse was not Dopplerable. And again, I'd like to really point out patient number 5, just because you think that you have a Doppler back on the in the OR after you pin it, that does not mean the patient goes home. The patients need to be observed, and again, this patient, 9 hours post reduction and fixation, had deterioration and had to be brought back to the operating room. And again, I'd just like to point out that the risk of nerve injury in this cohort is 3 times more common when you have a non-palpable pulse. We did have one compartment syndrome that was diagnosed when they showed up to clinic at 1 week post-op. They initially had a non-palpable pulse that was observed. This was present preoperatively as well as postoperatively. At the time of discharge, there was documented to be a palpable pulse and that the hand was well perfused and the patient was neurologically intact. But the patient presented to an outside hospital within 24 hours after discharge with increasing pain. and it looks like that not any intervention was done, and the Volkmann's was not identified until a week after this happened, despite the return of the palpable pulse. So what else can we use to evaluate blood flow? And so we did a study looking at findings. What does the artery look like when you use something like a duplex ultrasonography to really look at what is the flow of the breaker artery and the radial artery to the hand? And so kind of to skip forward, but this is a way this can be used, I think, in a real-life situation. This is an 11-year-old female who had a CRPP. She had a non-palpable pulse, but Dopplerable pulse preoperatively. And after the pinning on the table, she continued to have a non-palpable pulse, but it was, again, still Dopplerable. However, she woke up in PACU screaming in pain and had a lot of agitation and a lot of problems. And so when the decision tree was kind of started to decide whether or not she needed to be brought back, again, given that she did have a Dopplerable pulse, a duplex ultrasonography was done, and this is the waveform proximal to the fracture site. You can see this nice patent brachial artery. You see a really nice triphasic waveform, and then right at the fracture site, you can see that that waveform starts to get a little bit scattered. And if you look at velocity, the peak velocity has actually gone down threefold, from 120 to 40. And then again, looking distally down at the radial artery, you really don't see a waveform. It's very, very low flow, and you can really barely see that artery at all. And you see the technologist is really struggling to try to make out some sort of vessel in the radial artery. And when you kind of zoom up on these images, you can see all of this really turbulent flow. And so all these different color waveforms is turbulence and different velocities, and even some of its reverse velocity due to the stenosis at the fracture site. So if you remember anything about fluids, if you took fluids in college, this is kind of what you're looking at. And again, this is the brachial artery at the fracture site. You can see a really wide scatter. You don't really see a good waveform, and you can see the technologist is really hunting and pecking and really trying to find that brachial artery, which shows up as a myriad of different colors because of all that stenosis and turbulent flow. So this patient was explored, and the artery and the median nerve were found to be kinked and entwined in the middle pin, and they were released, and the patient overall did well. So the open anterior approach, this is the most common way to open a supracondylar, especially if you're exploring the neurovascular bundle, as in these cases. And so once you go through the skin, it's a lazy S incision where medially you extend it medially and proximally and laterally and distally. And you want to go carefully and bluntly. The biceps is your landmark. The neurovascular bundle is going to be medial to that, but you need to be aware that these fractures are so displaced that many times that neurovascular bundle can be anywhere. I've found it posteriorly. I've found it in the fracture. So just make sure you proceed with caution. I think this is something that most orthopedists should at least be facile with, trying to do this approach while you're waiting for your vascular surgeon to come in. And so here's a diagram of what this looks like. This is my planned skin incision, and this is really kind of almost, it looks almost exactly like this when you open it up, although many times the artery and the nerve are not steering you nicely in its anatomic position. So once you open it, sometimes it's very difficult to get length because it's very, very short. I like to use a Homan or a Freer to carefully lever that distal fragment out. You've got to be very careful because you don't want to iatrogenically fracture any of those pieces. And once you get out to length, the reduction really isn't any easier. You've lost all your soft tissue envelope. You don't have any periosteum, and really the almost easiest way to do it is to stick your thumb on it anteriorly and hold the elbow at 90 degrees and then have your assistant pin it blind. And if you don't have a resident or a fellow, you can put the 2 pins in the distal fragment, get the fracture reduced, and as you're holding it, have your scrub tech go ahead and drive those wires across the fracture site. So some of the take-home bullet points for pink pulseless supracondylar humerus fractures: you want timely reduction and fixation. Post-fixation, you want to observe them closely in the hospital for return of palpable pulses for 24 to 48 hours, and whether it's, we like to have the Doppler at the bedside so we can really hear that waveform and we can hear that sound and follow it. And a persistent loss of a Doppler signal of your radial pulse is highly suspicious for vascular injury, at least in our cohort. And since almost 10% of our pink pulseless supracondylar humerus fractures underwent vascular repair, if you do not have the ability for microsurgery or vascular surgery at your institution, I think you can give some consideration to transferring that to a higher level center if you don't have those resources at your hospital. Thank you.